Gun, ma'am. Switch on, ma'am. Stop it.
Good morning. Welcome to our session on secondary glaucomas. So, secondary glaucomas are very common and actually difficult to diagnose and treat also. I'm Dr. Roshni. I'm a consultant at Chaitanya Eye Hospital, Trivandrum. We have our speakers here today. Let me welcome them. We have Dr. Ronnie George, who is the Director of Glaucoma Services and Research at Shankar Nethralaya, Chennai. He will be giving the keynote address on tackling few different difficult types of secondary glaucomas. Welcome, sir. Next will be Dr. Meena Nair, who is a senior consultant at glaucoma services at Chaitanya Eye Hospital, Trivandrum. Madam will be speaking on secondary glaucoma following vitreoretinal surgeries. Welcome, ma'am. We have Dr. Beena Tangappan, who is professor at RIO Trivandrum. She will be speaking on pseudoexfoliation syndrome. Let's begin with the first presentation, which will be pigment dispersion syndrome and glaucoma.
So I invite Dr. Roshni R, who is a consultant, junior consultant glaucoma in Chaitanya Eye Hospital, to give her presentation on pigment dispersion. Pigment dispersion syndrome and glaucoma.
Thank you, ma'am. So, pigment dispersion syndrome and pigmented glaucoma comprise two sides of a spectrum of ocular disease, and dispersion of pigment granules from the iris pigment epithelium and deposition throughout the anterior segment is pigment dispersion syndrome. And the pigmented glaucoma is a secondary open-angle glaucoma from excessive pigment in the trabecular meshwork from PDS. The condition is usually bilateral. The mechanism of pigment dispersion can be described under Campbell's mechanical theory, which states that there is mechanical rubbing between the peripheral iris and the anterior zonular packets, causing pigment loss from the iris. The anatomical correlations to this theory are the concave peripheral iris configuration, close proximity between iris and anterior zonular pockets, and iris defects corresponding to number and location of anterior zonular pockets. There is yet another theory, which is abiotrophic theory, which states that there is premature degeneration of cells associated with genetic defects. PDS, though commonly sporadic, positive family history of glaucoma in 26% of patients have been noted, and an autosomal dominant pattern with incomplete penetrancy is reported. And chromosome 7q35 to 36 has been isolated and shown to increase the risk of pigment dispersion syndrome. Pathogenesis, there are definitely risk factors and an anatomical predisposition. Myopia and deep ACR are the risk factors, and other risk factors are posterior iris insertion to ciliary body, larger concave peripheral iris, inherent weakness of iris pigment epithelium, and long anterior zonules. So when the pigments are released, these pigments are engulfed by the trabecular meshwork endothelial cells. There will be a phagocytic overload, cell injury, cell death, and collapse of collagen beams and obliteration of outflow path, resulting in increased IOP and glaucoma. So this is a long anterior zonule trait, which is a new mechanism proposed for liberation of pigment in pigment dispersion syndrome. This is a variant of pigment dispersion and represents the radially oriented zonular fibers that insert more centrally than usual on the anterior capsule, and pigment dispersion results from this posterior iris shafting against these centrally located zonules. So these are the normal zonular insertion. These are the long anterior zonules, and these are the long anterior zonules which are pigmented. Reverse pupillary block is another mechanism explained in pigment dispersion syndrome. The iridolendicular touch in PDS works like a flap valve mechanism, and aqueous is allowed to travel unidirectionally from posterior chamber to anterior chamber. There is no escape of aqueous from the AC, and posterior bowing or rubbing of the pigment epithelium to zonular pockets occurs. But reverse pupillary block is not unique to pigment dispersion syndrome. It can be induced by exercise, accommodation, blinking, or eye movements even in normal eyes. So this is a UBM picture showing reverse pupillary block during accommodation. We can see the posterior bowing of the iris and the pupillary block. Clinical picture, the diagnosis of PDS is usually in the second or third decade. Pigmented glaucoma is more common among males, but PDS is equally prevalent. Approximately 80% of PDS patients are myopic, and risk of developing PDS increases as the extent of myopia increases. A young white myope is a typical case. Probability of conversion to pigmentary glaucoma at 5 years is 10% and at 15 years is 15%. Symptoms, early cases are asymptomatic. but episodic blurred vision with exercise can occur. Late cases, peripheral visual field loss followed by central visual field loss from glaucoma occurs. The signs, the corneal signs are important, which are the Krackenberg spindle on the endothelium, which are pigment granules phagocytosed by endothelial cells. These are not pathognomonic of pigment dispersion syndrome. These do not harm the endothelium, do not cause visual symptoms also. Other findings are deep anterior chamber, posterior iris bowing, mid-peripheral iris transillumination defects, anisocoria, the larger pupil being on the side of transillumination, and iris hyperpigmentation. Pigment accumulation on zonules and lens equator are named as Shee stripe and Sen-Meyer's lines. Gonioscopy is very important in pigment dispersion syndrome. It will show open angles, backbowed iris, and increased dense uniform trabecular pigmentation. The classic triad of pigment dispersion syndrome is Krackenberg spindle, mid-peripheral iris transformation defects, and trabecular meshwork pigmentation. The amount of pigmentation in the angle does not correlate directly with the risk of developing converting from PDS to pigmentary glaucoma, but is directly related to the severity of glaucomatous optic neuropathy. Pigment reversal sign is seen with aging, and older patients in older patients, as the pigment clears, the superior angle might have more pigmentation than the inferior. The reverse is usually normal, but this occurs in older patients. A quiescent or burnout phase occurs as the patient ages. Fundus evaluation, there is increased risk of retinal detachment in these patients up to 6 to 7%. Retinal breaks and lattice degeneration are common up to 20%. And when there is pigmentary glaucoma, optic nerve head changes of glaucoma occurs. The cause of the disease is more aggressive in pigmentary glaucoma than in a typical POAG. Differential diagnosis is pseudoexfoliation syndrome, uveitis, pigment dispersion with PCIOL, pigmented uveal tumors, trauma either surgical or non-surgical, and primary open-angle glaucoma also. Investigations, a good clinical examination is very important. Other investigations are gonioscopy, ASOCT, and visual field and OCT Arnold for the glaucoma. Ultrasound biomicroscopy is also very important because it shows the posterior iris insertion, iris concavity, and iridozonular contact. Treatment. Initial treatment is same as POAG, which is medical, but pigmentary glaucoma will have significantly increased and fluctuating IOP. All glaucoma medications are useful, first line of choice being the prostaglandin analogues. If the trabecular meshwork cells are not excessively damaged by the pigmentation, Rho kinase inhibitors might successfully alter the trabecular meshwork cells and limit damage. And myotics, there is a theoretical benefit because it reduces the iridozonular contact and increases the outflow, but it's risky in myopes with an added predisposition to RD and worsens the myopia, so patients will not tolerate myotics. YAG peripheral iridotomy, LPI would convert the posterior iris contour to a more planar contour, eliminating the iridozonular contact, but LPI's preventive role is considered controversial. American Glaucoma Society in a study failed to demonstrate the evidence to support LPI's benefit, and performing LPI to minimize the release of pigment in an OHT stage when already the damage has happened is not effective, but LPI might be effective in a young patient without irreversible trabecular meshwork damage. Laser trabeculoplasty also is considered controversial. Compared to argon laser trabeculoplasty, selective laser trabeculoplasty employs less energy over a short duration and selectively target the pigmented trabecular meshwork cells. But the success rate is not good. That it dropped from 85% at 12 months to 14% at 48 months in a study. Benefit is temporary and it's associated with complications like inflammation, IOP spikes necessitating surgery like trabeculectomy. So trabeculectomy ab externo is done when the medical and laser intervention is unsuccessful. It is the choice, and even after 8 years of surgery, a substantial and sustainable reduction of IOP over baseline was noted. About mix in pigmentary glaucoma, there is not an abundance of studies involving microinvasive glaucoma surgeries and pigmentary glaucoma. But trabectome, which is ab interno trabeculectomy using a handheld electrode, doing an ablation of this, an ablation of a strip of trabecular meshwork and the inner wall of Schlemm's canal is done, guided by intraoperative gonioscopy. This procedure was FDA approved in 2004. And a study found that at 12 months post-op, trabectome provided similar and safe and successful outcome in both POAG and PG. Zen gel stent is another mixed procedure which was FDA approved for pigmentary glaucoma and other open-angle glaucomas. And this is given its surgical mechanism, it could be a viable option in management of PG. Eye stent inject have been tried, but stent obstruction with the pigment has been a problem. And pay attention to clinical findings like slit lamp gonioscopy. Medical management like other OAG can be done. LPI, ALT, SLT all are controversial, and ab-externo incisional trabeculectomy remains the standard for refractory pigmentary glaucoma at present until further research provides less invasive methods are superior. Thank you.
I think discussion is probably have bigger audience.
So next speaker will be Dr. Meena Nair. Madam will be speaking about secondary glaucoma following vitreoretinal surgery. Madam is a senior glaucoma consultant.
I think you have to correct the timing because. Yeah. So good morning, everyone. My topic is glaucoma associated with vitreoretinal surgeries. I shall begin my session showing you a few cases. This first 53-year-old lady underwent a combined cataract with IOL along with 25-gauge pars plana vitrectomy with endolaser and silicone oil for rhegmatosis RD. And what do you see here? Looking at the contour of the iris, you can see the iris Bombay, and this patient had also undergone a choroidal drainage along with the procedure, and patient had a little early postoperative fibrin rise in the AC, and you can see in the lower picture that the iridotomy, which is patent, has relieved the iris Bombay. The next patient is a Maldivian who has presented a little later, say 3 months of diminution of vision history is there, with again with a rhegmatogenous RD. See the multiple holes inferiorly along with PVR, and patient also underwent a combined surgery, but here he has also undergone transcleral cryo along with silicone oil, and this is how the anterior chamber looked like on the first postoperative day with the fibrin membrane in front of the IOL. The third patient underwent vitreoretinal surgery for an epiretinal membrane, and the patient underwent again a combined surgery with the small incision vitrectomy, along with the only difference being a gas tamponade was used and SF6 tamponading was done, and the patient was good in the first post-op visit and at the 5-day visit, but except for a little posterior synechiae inferiorly, and by 10 days the patient came with an acute IOP rise with a lot of pain, intense pain in the eye, and this is how the cornea looked with diffuse edema and an iris Bombay. I'll be discussing these through the session. So transition from the conventional 20-gauge vitrectomy to the transconjunctival small incision vitrectomies may have improved retinal surgical outcomes, but definitely the post-operative IOP spike, which was a complication even with the traditional, still is common. The reported incidence in literature is 8.4 to 14.8% of secondary glaucomas, and the definition itself is a challenge because one has to differentiate what is the definition of secondary glaucoma. It refers to an immediate or delayed post-operative IOP rise more than 22 millimeters of mercury with or without an associated optic nerve damage or visual field damage. That's important. Second, further important thing is that progressive damage assessment in the post-op visits again is difficult because it's difficult to quantify the glaucomatous damage, which is very important in the management strategy. So in the post-operative period, IOP assessment is of paramount importance. Now, which tonometer would you use? So this study actually compares NCT, and in the pilot study it compared the Corvus with the GAT, and their further study compared NCT with Ovare with GAT, and it's all come up with the conclusion that NCT underestimates in silicone oil tamponade eyes, also in gas-filled eyes because of the gas compressibility. So Goldman is the gold standard. So in silicone oil tamponade eyes, the biomechanics is definitely altered, the corneal hysteresis is lowered, and the corneal resistance factor increases. So GAT is the gold standard, and literature says even tonopen has good agreement in such eyes. But it depends on what one is used to in practice. So how do you approach such cases? You have to assess whether it is an acute onset or a delayed onset IOP spike, whether it's an open angle or a closed angle, what was the vitreoretinal procedure that has taken place, whether it's buccal, whether it's vitrectomy. If so, with vitrectomy, what was the tamponating agent, whether it's oil or it's an intravitreal gas, whether there were any history of intravitreal injections, like especially steroids earlier, and any recent anti-VEGF injections, and the role of endolaser and PRP. So you have to assess the cause, the pathogenesis, which is the most important in outlining the strategy, and the severity of damage, whether it's only IOP rise or whether it's this damage. Dependent on that, you have to have a tailored approach to get the optimal visual outcome. So this table actually shows on the right-hand side various the incidence of glaucoma with the consequent based on the type of surgery, and you can see that the highest is for the intravitreal triamcinolone, where the onset has been at 2 months, and post-vitrectomy you can either have an acute rise in 48 hours period or a late rise. In oil-filled eyes also you can have both early and late eyes. Buccal produces by 3 weeks to 1 month, a 30% incidence is noted. The early onset, the causes could be a pupil block, could be an inflammation, and even sometimes choroidal hemorrhage can account for a acute IOP rise. And late onset is the steroid-induced or the trabecular damage because of the multiple surgeries or buccal effect and a chronic inflammation. Open angle, again, could be because of steroid-induced or trabecular block, post-vitrectomy by the blood cells and inflammatory materials, and the closed because of forward iris push of the iris lens diaphragm and peripheral anterior synechiae or a pupillary block. So coming to buccal, buccal, alters the total geometry of the eye, and so obviously the angle is distorted. And who are at risk? Those who have a pre-existing narrow angles, which is very important to know, and those who are older and who have an anterior buccal, because vortex vein compression with choroidal congestion and the rotation of the anterior rotation of the ciliary body with the forward shift of iris lens diaphragm accounts for the angle closure component, where the angle closure glaucoma is reported as 1.4 to 4.4%. So you can have an acute IOP rise with a pupil block even in buccal cases, and you have to document the disc findings in the post-op visits, because we can show cases which have normal angles and normal IOP, but progressively and sequentially when you follow up the patients, they can have damaged discs with fields which is difficult to identify. So we can see such cases in glaucoma with buccal, so you have to document the disc picture in your notes in the post-op visits. In buccal, medical management is usually successful. Cycloplegics to push the iris lens diaphragm posteriorly with the topical steroids aggressively, and you can use acrosuppressants, but miotics to be avoided. In buccal cases, again, laser not much of a role, and conjunctive trabeculectomy depends upon how much of conjunctival scarring is there, and cyclodestructives are always unpredictable, so GDD is definitely a good relief. In this context, I remember one patient of mine who is just 26-year-old, who is a young patient, myope, who actually presented on first examination, found to have a lot of flatness in both eyes, the right eye showing some sequelae of probably a regressed ROP, and so buccal was planned, and this patient was sent to the glaucoma consultant for a baseline evaluation to assess the angles, which is very, very important step. After surgery, like you can see in the lower picture, good buccal effect was noted, but we had a tough time because when you have lid edema and congestion, it's very difficult to record IOP in such eyes, and to follow up the patient when you get IOP spike at 3 weeks, whether it's because of steroid or whether it's because of a raised episcleral venous pressure, to really say that the patient has high IOP, because cornea need not be as edematous, and so it's difficult to monitor IOP in such cases. But a warning is that don't jump and do a filtration surgery. You can wait, and this patient took low steroids were given for about almost 5 to 6 months, and she's doing well. So after vitrectomy, the incidence, it is nice to note that phakics have a protective effect because the lens acts as a scavenger, so the free radical damage to the trabecular meshwork is to a great extent less, so phakics do better, and this is a reported incidence of 5 to 22 millimeters in 60% of eyes. They can have an acute rise or a chronic rise, which I already showed you, acute in 6 to 48 hours period, and chronic even after 2 months, and can go up to 5 years. You can have an open angle mechanism, and in chronic cases, you can have a rubiosis and NVG component as well. And if a buccal is combined with, or if you have, depending on the tamponating agents, further IOP rise. Intravitreal gas-induced, it's very important to note here is that you should always dilute, because undiluted concentrations of gas, whether it's the sulfur hex, SF6 or C3F8, both of which are FDA approved to use, SF6 can expand 2 times and C3F8 can expand 4 times. So as non-expansile concentrations have to be ensured, and maximum expansion is first 6 hours. And you can have a pupil block. The mechanism is with expansion, you have obviously a forward push of the iris lens diaphragm, and you can have a pupillary block. So you should not have high IOP, because obviously the risk of CRAO will be high if you have a high IOP. And if you have used a most important thing is that a lot of precautions, like you should warn the patient not about air travel, because when you ascend or mountain climbing, etc., the gas expansion risk is there. So you should know how long the gas lasts, should restrict such travel. Even scuba diving, and the patient comes up, it can, at atmospheric level, you can have expansion coming up. So that's the important of gas tamponating. But if you use a non-expansile thing, you can medically manage most of the time. In rare cases, only you need a sequential gas removal. Silicone oil filled eyes is very commonly met with. The incidence reported is 11 to 48%. Aphakics are at risk. And this patient, it is very difficult to assess when the total AC is filled with oil, actually, because it is the oil being transparent. And here you can see that you can see a kind of, when it is in the AC, you have to look for the sheen and look at the margin to really identify whether it's a pupillary block because of the silicone oil. So you can have an open angle mechanism because of trabeculitis, you can have angle closure mechanism because of synechial closure, or sometimes you can have an AC overfill where you may have to do partial removal. Combined mechanisms when the PI is close. So early presentation or late presentation has been already told to you. The patient shown down, actually, SOR was done. It was a young patient post-trauma, so oil removal, there's a little bit of oil left here, and such oils, whether need to be removed or not, is really, only emulsified oils actually have a detrimental effect. I think such small oils left behind in AC probably need not be aggressively removed with an AC wash. And emulsified oils causing hypopyon, if late, you can have ocular surface issues, and this is known to all that this will need surgery. So what are the surgeries possible? Either you can remove the oil alone, but combining with the glaucoma filtration surgery, always guarded because of risk of hypotony is there. So prefer that the VR surgeon tackles the SOR and then go for the glaucoma filtration surgery, because if the surgeon is planning a tube in the pars plana route, then there cannot be a risk of the oil blocking the tube. So these are the various options. Either you go for oil removal followed by the glaucoma filtration surgery, which could be TRAB or GTD, depending on the. So this is a patient where I would like to show how inferior iridectomy helps. That's called the Andos procedure, and it's a patient who underwent vitrectomy with buccal and is having not much of a damage to the discs. Post-injections against steroids, triamcinolone or Ozudex, they can produce a lot of rise, and the mechanism could be because of the injection-induced increased volume, and chronic IOP rise because of the trabecular meshwork damage. So these are the anti-VEGFs which are given, which can have direct toxicity or which can actually damage the trabecular meshwork. PRP or endolaser, again, the amount of laser energy used and the multiple procedures linked with can explain the IOP rise. You can have swelling of the ciliary body and forward shift, but if you avoid multiple procedures and you treat with anti-glaucoma drugs and steroids and cycloplegics, it works. So this is a summary of all the causes on the left-hand side with acute or IOP rises, which I have already explained in the discussions. Management, most of the time medical management suffices with intense steroids, cycloplegics, and anti-glaucoma medications. Like in this first patient, aggressive steroids brought it down in a week's time, after which the anti-glaucoma could be stopped. And lasers are very helpful, and what should be understood is that, like in the first case, the patient underwent several laser sittings at 10 days, 2 months, and 6 months post oil removal. So if you can keep do the sequential laser PIs, because they get blocked with fibrin, and maintain do not allow synechiae to set in, you can prevent damage. This is the third patient with the gas tamponade who had a patent iridotomy and an open angle always. So the patient also is doing good. But when pallor sets in, again, assessment becomes difficult whether to know whether it's progressing or not. So indications for TRAB is only when IOP is uncontrolled with maximal medications. But to do a TRAB, you should have good amount of superior conjunctiva available. That's the challenge. And GDDs, again, when the buckle is there, obviously the space is less for the GDD. But I think GDDs, a lot of modifications are there, but they do well if you can put the tube over the implant after dissecting the conjunctiva over the implant. Inferior quadrant GDDs have been proposed as modifications, pediatric valves have been proposed, and the tube insertion in the pars plana has been proposed as modifications, but post-op hypotenomy in vitrectomy eyes is always a complication. This is the last patient who is a one-eyed, and it's always difficult to say this patient is underwent vitrectomy elsewhere. You can see the inverse IOP1 and an advanced glaucoma and a shallow RD when the patient comes to us. And what do? Do you go for a limited TSCPC, or do you do a surgery, or do you do an SOR with AC wash? It's always a dilemma to the doctor. Now, amongst the MIGS, GAT is promising because it can bypass scarred conjunctiva, which is commonly seen in post-FIA surgery. So to conclude, glaucoma or secondary ocular hypertension is a common complication post-vitreoretinal procedures. Preoperative gonioscopy important. Identify those at risk for closure important. IOP elevation to be monitored and managed. Mechanism to be understood whether open angle or closed angles. Most of secondary glaucomas can be managed medically, and small proportion may require a laser or surgery. So recognize early and timely manage the IOP for a good visual outcome of the patient. Thank you.
Thank you, ma'am. That was very informative. Let me welcome Dr. Beena Thangappan. She will be speaking on pseudoexfoliation glaucoma. Dr. Beena Thangappan is a professor at RIO Trivandrum and a glaucoma specialist also. And over to you, ma'am.
Good morning to all of you. At the outset, I'd like to thank the organizers of KSOS and my dear friend Roshni for giving me this opportunity to talk on the topic pseudoexfoliation syndrome and glaucoma. Pseudoexfoliation glaucoma is the most common identifiable cause of open-angle glaucoma worldwide. It's more aggressive and a rapidly progressive condition than primary open-angle glaucoma. It's basically a stress-related condition, systemic condition, characterized by deposition of pseudoexfoliative material within the anterior segment of the eye and other body tissues, giving rise to various ocular and extraocular manifestations. So I'll be discussing a particular case here, and as we go through it, I'll be discussing the various essential and the practical aspects related to this particular condition. This 65-year-old male had presented to our hospital from referral hospital as a case of primary open-angle glaucoma and was on anti-glaucoma medication for the past 2 years. Ocular examination revealed right eye visual acuity of counting fingers 1 meter. Rest of the anterior segment was normal except for nuclear sclerosis of grade 3. Left eye examination visual acuity was hand movements, and as you can see from the picture, there is evident pseudo-exfoliation present at the pupillary margin with loss of pigment at the pupillary ruff with a relative afferent pupillary defect. There was nuclear sclerosis of grade 3 to 4, and there was evident phacodonosis. IOP by applanation was right eye 44 and the left eye it was 50. Gonioscopy revealed a hyperpigmented posterior trab in all quadrants, which was seen in both the eyes, and there was a pigmented Schwalbe's line and Sampolisi's line, which is a wavy line of pigmentation just in front of the Schwalbe's line. So this is said to be a characteristic feature of pseudoexfoliation syndrome. And also in case of unilateral pseudoexfoliation, always try to look at the other eye, but other eye might show features of a hyperpigmented posterior trab. Pupillary dilatation is very essential in these cases. As you can see, left eye the pseudoexfoliation was evident, but right eye, interestingly, in this patient, it showed the zones which you see characteristically in case of pseudoexfoliation. So here you can see the peripheral zone with the radial striations. Now this is said to be the consistent finding in case of pseudoexfoliation syndrome. So this is a classic picture which you usually see, that is the target sign or the bull sign which you see, where you can see 3 zones, where the inner zone corresponds to the size of the pupil. The intermediate zone, clear zone, is due to the movement of the pupillary margin, which brushes off the pseudoexfoliative material, and the peripheral zone is a consistent zone. So when you dilate the pupil, always look for evidence of early zonulopathy in such eyes. So what is evident is you can see that there can be an increase in the gap between the edge of the pupil and the pupillary margin. Now this will be more evident if you ask the patient to look down or sideways. Again, in these
So that's it. So again, in these cases, when you have a dense cataract and you cannot visualize the disc, B-scan is of some help in such that you might get a relative size of the optic cup in such cases, though the edges of the disc may not be, of the cup may not be discernible. U-beam is of very much importance here because you can detect pseudo-exfoliative material on the zonules, which is an earlier sign, apart from finding pseudo-exfoliative material on the anterior lens capsule and the central portion and the peripheral portion and all. Specular microscopy is of importance, especially if you're planning for a particular, any type of surgery in pseudo-exfoliation cases. So the diagnosis was revised as a case of pseudo-exfoliation glaucoma in both eyes with optic atrophy in the left eye and nuclear sclerosis in both eyes. So though both the pseudo-exfoliation syndrome and glaucoma may present clinically as a unilateral disease, about 1/3 of these cases can get converted to bilateral disease over a period of 10 years. Studies shows that about 30 to 40% of patients with a pseudo-exfoliation syndrome develop glaucoma. So these are the management options which you have, of which coming to the medical management, pseudo-exfoliation syndrome and glaucoma shows a very poor response to medical treatment compared to primary open-angle glaucoma. Remember, the target IOP has to be kept much lower in cases of POAG than in POAG. Interestingly, they show a good response to prostaglandin analogs. Again, the response to monotherapy is very less. You have to go for combined therapies, fixed dose combination of any of the glaucoma medications which you usually use. Coming to the role of laser, if you have occludable angles, there is a role of laser iridotomy. Again, a less common mechanism in this case of glaucoma is angle closure mechanism. Probably it may be due to the zonular dialysis and you have an anterior movement of the lens and there is an increased lens thickness noted in these patients. When you have an open angle, there is a role of laser trabeculoplasty. Selective laser trabeculoplasty is said to be effective. Maybe it is because of the increased trabecular pigmentation and the absorption of laser energy. As this was shown by the light study, one of the commonest complications but encountered here is early iopic spikes. But again, this is not much effective in Indian sites compared to Caucasian eyes. Coming to the role of surgery, in advanced glaucomatous damage or high IOP more than 30, filtering surgery, especially trabeculectomy with antifibrotics is preferred, and implantation of drainage devices only when it is a failed case. We have limited studies there. In early to moderate stage glaucomatous damage and when you have an IOP less than 30 control with maximum tolerated medication, there is a role of minimally invasive glaucoma surgeries, of which the recently the GAT is emerging as an effective treatment option. And as such, we have again limited studies with relation to mix in pseudo-exfoliation syndrome and glaucoma. Combined surgery is another option where you can go for cataract combined with trabeculectomy or you can combine with the GAT procedure. So coming back to this particular case, patient was initially managed medically with topical medications to bring down the IOP and patient was planned for a combined surgery, right eye trabeculectomy with mitomycin and cataract surgery with PCIOL. So again, cataract surgery in pseudo-exfoliation glaucoma, this is a very challenging situation. Patient, you need detailed counseling regarding the possible preoperative, intraoperative and postoperative problems which might be encountered. You can have poor pupillary dilatation to start with, be ready with the pupil dilating devices, the hooks or expanders or whatever you prefer. Again, corneal endotheliopathy, you have to use generous viscoelastics and cohesives are better preferred. Weak zonules is usually associated with this condition, so minimize the stress on zonules during all steps of the cataract surgery. Start with a larger capsular axis, use of capsule tension rings, segments or capsular hooks depending upon the amount of pseudo-exfoliation which you have, the zonular dialysis which you have, use of a 3-piece IOL. And again, it's better to go for the capture method or the IOL trap technique where you put the haptics onto the sulcus and you can place the optic within the rhexis margin. Post-operatively, you can expect a marked post-op inflammation with fibrinous reaction, so you have to aggressively treat with anti-inflammatory steroids and NSAIDs. Fortunately, in this case, the surgery had gone uneventful with IOL implantation and 2 months post-op, the vision had improved to 6/12 with a good functioning bleb. And patient was on regular follow-up for about 2 years. But after that, until that time, the IOP was controlled, and after that, we lost the patient for follow-up. 2 years later, the patients presented with loss of vision in the right eye. Vision had dropped to hand movements and the IOP was 22. As you can see in the right eye, what had happened was there was a spontaneous dislocation of the IOL in the back. The left eye vision had dropped to PL and IOP was 30. So this is a late post-op complication in these patients. You can have capsular contraction of fibrosis, you can have spontaneous subluxation or even decentration of IOL. So what I'm planning to do is removal of the IOL with thorough vitrectomy and a secondary IOL implantation, for which I might need the help of a vitreoretinal surgeon. So meanwhile, I've just given a phakic correction for this patient where the vision has improved to 618 and patient is on multiple anti-glaucoma medications, especially in the left eye. So 3 months post phakic correction, patient is having stable IOPs and is on follow-up. So overall the prognosis, it has got a very rapid progression compared to POAGs. The IOP, mean IOP tends to be higher in these patients with greater 24-hour IOP fluctuations. There is greater vulnerability of the optic nerve to damage in these eyes. It is found that the neuroretinal rim damage is more diffuse here in contrast to the sectoral loss which you see in POAG with greater visual field loss and poor response to medication. So overall it is a poor prognosis compared to POAG. So to conclude, controlling glaucoma and pseudoasphyllation syndrome is very challenging. Patients have to be regularly followed up as a glaucoma suspects. And because it's a more aggressive condition with increased risk of blindness, there's a need for early recognition and appropriate management which can help prevent the progression of visual loss. Thank you.
Thank you, ma'am. That was pseudoexfoliation well explained. Now, I'll welcome Dr. Ronnie George for the keynote address. Dr. Ronnie George is the Director of Glaucoma Services at Shankara Netralaya, Chennai. Welcome, sir.
Yeah. Thank you, Dr. Roshni, for the kind invitation to speak here. So I'm going to be talking to you about a bunch of glaucomas. And among the phacomatosis, I'll speak a little bit about Sturge-Weber and neurofibromatosis. So your Posner-Schlossman syndrome is actually fairly rare. It's usually unilateral and typically comes with episodic high IOPs. You may have mild inflammation during those episodes, and the symptoms are usually blurred vision, pain, and colored halos. But sometimes patients are quite asymptomatic except for the blurred vision. And if you look carefully, you might occasionally see a few coin-like KPs there, or you will sometimes just see the endothelial mark of previous KP. They also sometimes come to you with corneal edema like this, and that's a sign of other underlying issues as well. So this is usually, you see them 20 to 50, it's commoner in males and women. The etiology was supposed to be unknown, but in the recent past, people have been suspecting more and more that a lot of these patients have a viral etiology. And when you actually look at the AC tap done in Posner-Schlossman, you find that for the CMV positive eyes, a substantial proportion actually are CMV positive. So almost 50% are CMV positive when you do a AC tap. And among the patients who are CMV positive, they're more likely to have a more severe form of glaucoma. While traditionally it was thought that you don't actually get glaucomatous damage in Posner-Schlossman, that's not really true, because when you get multiple attacks, you can land up with damage. So you need to do a PCR with an AC tap to rule out a infectious etiology. And the reason why you need to figure out whether there's a viral etiology to it is because whenever you have a viral etiology, your outcomes are a little worse. So when you look at patients who have a viral etiology, generally the high IOP spike is much higher, the maximum IOP is much higher. They're much more likely to convert to glaucomatous damage. So if you identify them, you can actually, and this is individual patients, you can see that most of them had higher IOPs than the patients who had non-viral etiology. So in terms of control, also medical control is a little easier in viral, provided you start the antivirals, and surgery rates are similar in both. So the management is three-pronged. Traditional management of steroids and cycloplegics will take care of it most of the time. Antivirals will help if you have a viral etiology, and when the pressures are raised, you may need to add medications and surgeries. So for me, when I suspect a Posner-Schlossman, what I typically start off with is I start off with the steroid. and I may add a anti-glaucoma medication depending on the pressure. If the pressures are just 30, 32, I might just start on the steroid and call them back in a week or two, see what happens. But one thing that you have to watch out for in these patients is you can actually land up with really high pressures. They sometimes come with 40 and 50, in which case you have to cover them with some other glaucoma medications too. When they come with recurrent attacks which are not very severe, you can even use a soft steroid instead of prednisolone to try and get the inflammation under control. When you're talking in terms of viral infections, then basically you're looking at CMV. So the drug of choice there is valganciclovir 900 milligrams per day for 2 weeks. Then you can reduce to 450 milligrams per day as a maintenance dose. Keep in mind that sometimes these patients have to be continued on the medication for years also. In terms of medical management, you can probably use almost every drug except the prostaglandins and pilocarpine because of the underlying suspicion of viral or inflammatory issues. Laser trabeculoplasty is generally not advisable because the primary source of is trabeculitis, and when you're going to go and tickle up the trabecular meshwork again with SLT, it's really not helpful. And so, so this is one patient who we've been following up for years actually, as Poshnell Schlossman, each of these episodes, and this is about some years back. And finally, when we did the cataract surgery, we did a TAP, turned up with CMV retinitis, and we started him on medication. And following that, after 1 year of medication, he never has had a recurrence. So if you're doing a surgical intervention in these patients, it's worthwhile to actually do a TAP at that point in time. And surgery is basically similar to everything else, except that you tend to tie them down tight, just like with any other uveitic glaucoma, and you tend to be a little bit more aggressive on the steroid because these are hot eyes. Now, Grant syndrome is again very rare, and it's primarily an inflammatory glaucoma. There is a sort of overlap with Poshnell Schlossman and Grant, but the difference is that in a Grant syndrome, you will actually see KPs on the endothelium, on the angle. You may not see very much other inflammation, but you will see these KPs. And treatment is very similar to what you do with Poshnell Schlossman because you treat them with topical steroids and anti-glaucoma medications, and they usually respond very well. So this is difficult to see here. It's very, very difficult to photograph a KP in the angle because it's transparent or translucent. So if I can see it a little bit here, if you can actually look at this little bump there, that is actually a KP in the angle. But what you will normally see is this. You will see these pigmented KPs. So this is somebody who's had a few attacks. There are few KPs here which are transparent, but these pigmented old KPs on the endothelium is what you will see on gonioscopy. And this is usually fairly confirmatory of some sort of angle issues. We'll move to the eye syndrome. And so eye syndrome basically has three components. You have corneal alterations, angle alterations, and iris alterations. And you have typical features on the endothelium, and one of the things with eyes is you have to have a high index of suspicion. I have at least seen 10 patients who are being treated as uveitic glaucoma or as primary uveitis because they think those high PAs are because of inflammation. But you take a close look and you realize it is actually eyes, and the patients can be off the steroid and everything else, and you just need to take care of the glaucoma, because it can present in various ways. So your angle alterations are typical. You see these high PAs, and sometimes they're so high that you can actually see the ciliary body very clearly. And this is basically because there's a cellular membrane extending over the endothelium, which is pulling the iris anteriorly and closing the angle. And you can get, so this is the iris nevus Chandler syndrome and essential iris atrophy are the three components of it. You can get it in any combination of these. So it's actually a fairly, it has fairly different presentations. And again, this is one more condition where of late viral etiology is suspected to be contributory. In terms of management, you can use any glaucoma medication. SLT is not really a great idea because it's an angle closure. You're really not going to have much of help. TRAB and AGV are the two things that we look at. There's really no role for minimally invasive surgery here. There are a few caveats when it comes to whether you're going to do a TRAB or whether you're going to do an AGV, and we'll just look at a few cases for that. Very, very important to do the gonioscopy before you decide on a surgical procedure, because where the synechiae are will make a lot of differences in your surgical decisions. So this is actually an unusual patient. So if you look at that, you can see a little endothelial changes. You can see PAS here. It doesn't photograph very well, but actually there are synechiae all around like that. And this is the left eye of the same patient. That is not a PI, that is an iris hole. And you can see some ectropion over there. This is what the disc looks like in the left eye, fairly tortuous vessels. This is what the field looks like in the left eye. And so this, what I just showed you, is a very, very rare bilateral presentation of eyes. Both eyes endothelial changes were low. It's a very rare presentation, so, but you can keep in mind that it can occur sometimes. Now, this patient, basically again an iris hole, you can see the altered iris pattern, you can see the distorted pupil, and you can see PAS here also. So this is what gonioscopy looks like on this patient. So there is all closed, but this bit is open. So this bit actually is open, and this patient, when we finally did surgery, we actually did a trab localizing it to this area, because you have an opportunity here. It's not that this trab is going to work forever. Over a few years, this is also likely to close, but then you have actually managed to make use of an opportunity at that time. Very often you are left with no opportunity but to stick in a tube, because sometimes this is what the iris is going to look like, completely atrophic, and patient has had cataract surgery before. You can see that the endothelial changes have started to cause a corneal decompensation, and you're left with no options for a tube. The better location for this tube is in the sulcus rather than in the anterior chamber. Coming to Sturge-Weber syndrome, so this is the typical skin subcutaneous hemangioma that you will see with Sturge-Weber syndrome. I don't know whether you can make out, but you can also get a conjunctival blush, which you can see in this patient, that little redness inside the conch. So it has a fairly high incidence of glaucoma, and basically it's this, you can see all these signs: dilatation of vessels, and that will come to a little later. You can see blood in Schlemm's canal. This is not my image, but because blood in Schlemm's canal is a little difficult to document, by the time you take them there, you don't always see it. The absence of blood in Schlemm's canal does not necessarily mean that there's no increased epithelial venous pressure. You can see hemangiomas on the fundus, and you need to be careful about that. So when you see this in children, they behave very, very similarly to any primary congenital glaucoma. When they're seen in adults, you do get trabecular meshwork changes similar to what is seen in open-angle glaucoma. But most of the issues are because of the raised epithelial venous pressure, which cause issues with outflow. And this is a small series of patients within our hospital, and you can see how most of them present. You see almost 50%, in fact more of them present with 3/60 vision or less, because it's very often unilateral and they don't realize, especially in younger children, you don't realize it. You can get, most commonly it is unilateral, but you rarely can get bilateral eyes when you have very, very large hemangiomas. You do have associations with meningeal hemangiomas, you do have patients with facial and upper lid is common, but keep in mind that these patients can have leptomeningeal meningiomas, and before you plan them for any surgical intervention, it's important that they have neuroimaging. And look at the intraocular pressures at which they present. So a good proportion of them present with very high IOPs, more than 30, 40 or 50, and that's something that is common. And gonioscopy, most of them will have open angles. You will see blood in Schlemm's canal in about 50%, but not in everybody. And like I said, many of them come with very significant biaquate scotomas. And on ultrasound, 5 eyes showed choroidal thickening. So management for most of these eyes, we actually did. So if it's a child, most of the time what we tend to do is we tend to do a trabeculotomy, because you don't want to do a trabeculectomy because of the risk of choroidal hemorrhage, of choroidal effusions. So most of the time, since it's unilateral, you already have a slightly enlarged eye, you probably amblyopic, you try and be as conservative as possible, do a trabeculotomy with a pre-placed sclerotomy. You can do a trab plus MMC if you are really, if the pressures are really high, or you can do an hemaglocoma volvulus. That's the way that we do it. So we tend to put in choroidal sort of sclerostomy for everybody, but even with that, out of these eyes, about 20 eyes, we had 7 eyes with either a serous RD or choroidal effusion post-op, and 1 late onset RD, which is probably not really related directly to the surgical intervention. So, yeah, so basically we just do a prophylactic sclerotomy. It's very easy to do, we just place it. And what I want you to see is here, this leash of vessels that you can see next to the, that leash of vessels that you can see next to at the edge of the conjunctiva. That network of vessels is a very, very typical feature of raised epithelial venous pressure. But not showing. Yeah, okay. So this one. So it's very, very typical of Sturge-Weber. So if you are doing surgery on any eye and you see this picture when you're doing your cautery, then ask yourself whether you have missed a raised epithelial venous pressure, because that's very, very typical. Anyway, the other option that you have is you can actually use oral propranolol 2 milligram per kg. Thank you. In 2 divided doses for at least a week before glaucoma surgery, which is continued for 6 to 8 weeks after glaucoma surgery. Sushmita from PGI is very strongly believes in this. So this is an option, but keep in mind that it's a beta blocker, and in children you need to be aware of the issues associated with it. So, but even with this, you look at the number of effusions that were there. There are a significant number of patients who had effusions. Even this 1, 2, 3 patients out of the 15 had effusions. So you can't rule it out completely. So Sturge-Weber with glaucoma, like I said, medical management is the first step. After that, goniotomy with prophylactic sclerotomy in children, and AG with prophylactic sclerostomy in adults. I will never forget. I will never forget one patient who had ADHD, about 7 or 8 years, very bad ADHD, very difficult to control. IOPs were quite high. So I decided I'd do a trab. So I did a trab, I put in 2 sclerotomies placed. I had no problem on table, tied it down tight. Post-operative kid is very difficult to examine, but he was doing okay. Then he came at 10 days, massive swelling. He could not open the eye, his mother is panicking, everybody is panicking, I am panicking. And because it is looking, you don't know whether it's an infection, whatever. So anyway, managed to get the kid down, catch him, stick a speculum somehow into the eye because you could not open the lid. When you put the speculum in, you can see a massive chemosis all around with the cornea right there sunken down in between. AC is formed. What has happened is he's had a delayed effusion. Because we leave those sclerotomies unsutured, the whole of the effusion has come out. He just required steroids for about a week or 10 days and he settled down. But this is one of the reasons why you have to be really, really careful in these children. You have to do the sclerotomy because when it's bad, it can be really bad. And that kid finally recovered completely without any issues. So there are a couple of slides on this, and this is basically glaucoma and neurofibromatosis. And here what happens is the ciliary body may show thickening, and there may be, this can be because of infiltration by a neurofibroma. You can also get ectropia and UVA, and this is supposed to be secondary to the endothelialization of the iris leading to tractional forces, resulting in ectropia and UVA. So this is the first case that you see over here, and it's subtle, but all you are seeing is this ectropia and UVA on one side. There's nothing much else. But when you do the gonioscopy, you can see that, that the angle is actually closed on one side in one patient and open in the other. Okay, so basically that ectropia and UVA and the angle closure are what is responsible for the glaucoma in this patient. So in the case 2, you can see this bilateral ectropion. And this patient, you can see the leash nodules. The leash nodules are those little hypopigmented, I've seen better in this picture. And you can see the ectropion there too. So there's a wide range of, these cases are treated just like any other case. You treat them medically. Because of the angle closure, you may need to consider surgical intervention, but it's not a pupillary block glaucoma, so they don't really require a YAG PI. So the secondary glaucomas have a wide range of presentation, and you have to be aware of them because most of them have disease-specific interventions. Thank you once again for the kind invitation.
Thank you, Dr. Roni. That was very informative, and thank you for sharing your experience with the difficult cases also. Now we are open for discussion. Any questions from the audience?
For all patients of your, or you do it, reserve it only for surgery to know whether it is CMV positive because you only said such cases?
Yeah, so the first time the patient comes to me with typical Posner-Schlossman, I don't typically do an AC tap. But if they come with a second attack, then I might consider asking our UVI colleagues whether they would like to do an AC tap. That's.
Then you showed a few cases of needle support associating with the portine angiogram. Actually, even I have seen a few cases.
Yes.
Like that. So is there an incidence, greater risk of secondary glaucoma in such eyes, or is there any different?
There are a couple of reports which say there is slightly higher risk of glaucoma, but I really don't think so. I think the nevus aorta is just incidental because of a bleed in that area, a previous bleed in that area.
I have one question. I have this patient of Sturge-Weber syndrome who is managed with medications, but IOP is still uncontrolled, but we are given a combination of, I think, 3 drops and plus 1 more. So when do you advise surgery for such patients?
Exactly at this time.
This thing. So,
but I would put in a pre-placed sclerotomy. It's not difficult to do. Any of us can do it. It's not. You don't require any special expertise to do it. You just make a linear incision about 3.5 millimeters behind the limbus. Just gradually dissect till you can see bicoroid. Open it up and maybe just cauterize the edges so it stays open.
okay.
You just don't suture it after that. Close the conjunctiva over it, and then proceed with your surgery as you should.
I mean, just a modified trabeclectomy with antifibrotics.
You can do that. Tie it down tight.
Okay.
So that's the only thing that you put pre-placed sutures, close it as soon as possible, tie it down tight, make sure that there's very little filtration on table, do a controlled releasable release later.
Okay. Any role of this cyclophotocoagulation patients?
If it's poor prognosis eyes, you can do it, but not, I think, as primary. Especially if it's an adult, you can usually manage. It's not a big challenge.
Okay. Thank you, sir.
Okay, so that finishes the session, and I would like to extend my sincere thanks to all the speakers for joining with me in this session. Thank you.